So good morning, good afternoon, good evening, whatever you are. Welcome to another webinar that is organized by Initiative's webinar series. We are going to talk today about monitoring regional oxygen saturation, assessing the value of near-infrared spectroscopy in clinical practice, featuring Dr. Jeffrey Green. Next slide, please. Anytime that you have a question, please go to the right side of your screen and use the panel there to send us a question, and we will try to answer as many as we can at the end of this event. Next. My name is Fernando Yuste, and I am Senior Global Principal Training and Education Specialist at Medtronic. I've been working in the medical device industry for over 20 years in many different positions. I am a doctor in physics, and I have an MBA in marketing from ESADI Business School in Barcelona. Next. And Dr. Green is a board-certified anesthesiologist with the Virginia Commonwealth University Medical Center since 2001 and the Boyan Keenan Professor of Anesthesia Safety. While Dr. Green is recognized for his expertise in cardiothoracic anesthesiology and patient safety, he is also dedicated to quality and performance improvement throughout the health system. In that capacity, he serves as Assistant Medical Director for Performance Improvement at VCU Medical Center. Dr. Green provides anesthesia to patients undergoing complex cardiothoracic procedures such as coronary artery bypass grafting, valve replacement surgery, heart transplants, ventricular assist device implants, and total mechanical heart replacements. He is board certified in perioperative transesophageal echocardiography, a complex procedure that uses ultrasound to take images of the heart and blood vessels before, during, and after surgery. Outside of his clinical rounds, Dr. Green teaches the next generation of cardiothoracic anesthesiologists at the VCU School of Medicine and trains fellows, residents, and students in perioperative TEE. He also keeps busy with his role in both the American Society of Anesthesiologists and Virginia Society of Anesthesiologists. Next, please. Before we start, we have to say that the speaker is a consultant for Medtronic in the Medtronic speaker bureau. He is also responsible for all the content and any necessary permissions. The support has been for this event has been given by Medtronic. Next, please. This is a CME accredited event. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through the joint providership of Synaptive and Saxe Healthcare Communications. Synaptive is accredited by the ACCME to provide continuing medical education for physicians. Synaptive designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Next. This event is also accredited for continuing education hour for nurses and respiratory therapists. Next. With that, please join me welcome Dr. Green.
Thank you, Dr. Yuste. Thank you for joining me today to talk about monitoring regional oxygen saturation, assessing the value of near-infrared spectroscopy in clinical practice. I appreciate the support from Medtronic in order to provide this presentation. First are a couple of learning objectives. We'd like the participant to be able to discuss the detection and monitoring of cerebral saturation, describe the use of NIRS to assist in the detection of cerebral desaturation, and discuss the evidence to support the use of NIRS in improving postoperative outcomes by the end of this presentation. So here's a brief overview of what we'll talk about today. We'll talk about really a couple of problems that we're facing in healthcare and how near-infrared spectroscopy can be a solution to the problem. We'll talk about the value proposition that cerebral oximetry brings. We'll talk very briefly about how it is used and how the data that's received from the device is validated. And then we'll spend the bulk of our time talking about some clinical evidence and some outcomes related to studies in the most prominent areas where the device is used. And then we'll conclude and take some questions. So here's a problem that we're facing, particularly in the United States, where the population of patients age 65 and over continues to grow along a curve that you see here in front of you. Here we are in 2020 with approximately 55 million patients over the age of 65. And here's where we are anticipated to go in 2050. This certainly creates a problem for us or a challenge for us in healthcare. Patients living longer, have more surgical procedures, particularly at later ages where they tend to have higher comorbidities and higher risk for complications. So the challenge that we face is how to keep these patients safe from complications as they undergo more and more procedures. And the prudent thing to do is use all of the technologies at our disposal to maximize the outcome for these patients. Here's a concomitant problem. This is the growth of comorbidities. And here you can see this is the percent growth relative to the starting point in 2013 of various comorbidities. You can see if you look, if this is the growth, relative growth in total US population, you can see that all these comorbidities, dyslipidemia, arthritis, hypertension, diabetes, cardiovascular disease, heart attack, and stroke are all growing faster than the growth in U.S. population. The only exception is asthma, which is actually the incidence is going down and projected to continue to go down through 2025. What does this do? This increases the pressure on us in healthcare in order to reduce these, to treat these chronic conditions and reduce the complications that are associated with patients with these chronic conditions, particularly when they're undergoing surgical procedures. Speaking of complications, this is data from NISQIP, the National Surgical Quality Improvement Program, which is the best, the highest quality program aimed at reducing complications. And while you can see that the overall trend in complications is decreasing, both in complications overall, as well as mortality and serious complications, you can see that when you employ a program such as NISQIP, it doesn't do really too much better to reduce the incidence of these problems. And so complications are very common. You can see that the percentages where these things occur here, 4% have complications, here about 1% mortality, and incidence of serious complications near about 1.5%. These are pretty common. And although they're declining, we apply a very complex and expensive program like NISQIP, we can't get rid of them entirely. The pressure to reduce these complications, along with the concomitant cost and length of stay, is great and will continue to increase in healthcare as the cost associated with healthcare in the new world of bundled payments continues to be heavily scrutinized. So here's one potential solution, and that's a regional saturation monitoring. This is a non-invasive monitor that will help us both guide management as well as detect hidden threats and problems that can compromise recovery, leading to worse outcomes and increased length of stay. If you try to assess the value of this monitor, you will see that the improved patient outcomes, efficient utilization of resources, increased patient safety, far outweigh the costs associated with the device. A non-invasive monitor adds very little cost beyond the cost of disposable sensors to the treatment of patients. And therefore, when you look at the overall balance, you can see that there's a value associated with using the device. Before we go too much further, we'll just do a couple of quick definitions of terms. When we talk about SaO2, this is the systemic arterial oxygen availability. This is the amount of oxygen in the arterial blood. We can measure that with SpO2, pulse oximetry. This is a monitor, typically a finger sensor that depends on pulsatile blood flow. But the limitations of pulse oximetry is that it only measures oxyhemoglobin in arterial blood in the arterial side of the circulation. So this really tells you about oxygen availability and does not give you any information about oxygen delivery to the tissues and whether or not that's adequate or not. Going one step further, you can use an invasive SvO2, which is a mixed venous oxygen saturation. This is closer because it gives us a global picture of oxygen use and as well as oxygen delivery and consumption, but it's not very good at detecting any regional compromises in oxygenation. And finally, we have near-infrared spectroscopy regional saturation, which measures the difference between oxyhemoglobin and deoxyhemoglobin. And this is really the venous reserve capacity or a measure of oxygen balance because it gives us information about both tissue supply and tissue oxygen extraction in a specific region or tissue, most commonly used at the site of measurement at the brain. So what is NIRS and how does it work? You can see here a schematic of vessels in the brain, which are connected by a capillary bed. The reflectance spectroscopy measures hemoglobin saturation in this microcirculatory environment in real time. Because we know that the capillaries contain about a 25% to 75% mixed arterial venous sample, the information that we get from the device gives us a mixed sample. The device is important because it helps us before functional changes occur. We're able to see the status of oxygenation in the brain. Here's a schematic of how the sensor works at the site of measurement, in this case here the brain. This is a picture of the sensor with a single light source and two detectors. The first is a shallow detector. The last second is a deep detector that's spaced further away from the light source. At least some of the light leaving the sensor will follow a banana arc type pattern like this, where the light will go through the outer layers and into the skull. And in the deep detector, at least some of the light will go penetrate beyond the skull to a depth resolution of at least 2.5 centimeters. And you can see that if you subtract the shallow arc from the deep arc, what you'll be left with is a signal that represents oxygen saturation at the level of the blood vessels at the level of the brain. At the time these slides were prepared, you can see the available devices that are cleared by the FDA in order of when they were approved. Importantly, there are differences between all of these devices. They attempt to get at similar information, but they do so in very different ways. They use different types of lights. They use different types of wavelengths of light, and they use sensors that have different numbers of wavelengths as well as different variations in distance between the measurement of these devices. For example, we know that INVOS measures to a depth of 2.5 centimeters, whereas the Foresight device only measures to about 1 centimeter deep. These, importantly, because they obtain information differently from each other, it's important not to use the information from one to make assumptions about another. The algorithms within these devices are all different, and so you can't compare the information from one sensor to another, nor can you interchange the data from studies that were done with one device and apply that to the same to another device as well. Brief information about targets and thresholds and how to use the device. We know that from evidence that I'll show you in just another couple of slides that normal values run between 60 and 80 in healthy patients. The device displays information bilaterally. There's a sensor on each hemisphere of the brain. left and here on the right. It gives you trend information over time. The thresholds that are considered important for cerebral desaturation, that if a patient desaturates more than 20% from their baseline value, this is a intervention threshold, which we want to prevent the patient from desaturating below that level. If a patient desaturates more than 25% from baseline or below an absolute value of 40, we know that's a more critical threshold, at which point intervention is required to prevent an adverse outcome. Here's some information on the validation of measurement for the device. This is a study of 42 healthy volunteers at 5 different levels of oxygen saturation, both at normocapnia and hypercapnia. On the left, you can see regional saturation compared to jugular venous saturation, and you can see a pretty close correlation at various levels of end-tidal CO2 between regional saturation and jugular venous saturation. And you would expect that if this device were valid, that it would correlate pretty closely with jugular venous oxygen, which is the blood leaving the brain after whatever's left over after extraction. On the right side is a little different measure. Here you have this regional saturation along this axis and a new parameter called field saturation, which is simply a calculation of 75% venous blood sampled from the jugular venous circulation, added to 25% arterial blood sampled from an arterial line to approximate the content of blood in the cerebral vault. And if the device were valid, you would expect those measurements to correlate very nicely, which you see here along this line here of correlation with an R value of 0.76, which is a pretty good correlation. If you take the information that you obtain from those 42 healthy subjects and you plot them along a curve such as this, you will see that the values in blue are your regional saturation, while in orange is your jugular venous saturation. The values have a median range from about 60 to 80, which you see would be the normal range. The regional saturation is slightly shifted to the right, as you would expect, because the regional saturation adds in the arterial component to the jugular venous saturation, which is just venous blood. Later on, I'll show you what this curve looks like in cardiac surgical patients, which is a little bit different than what you see here in these healthy volunteers. And at this point, we'll move on and talk about some clinical studies and talk about some outcome measurement with the device. First, we'll look at cardiac surgical patients and cardiac surgical studies. So this first study is one of the older studies, yet still very important. This is a study of 200 patients undergoing coronary artery bypass grafting. It was done in a single center. It's a randomized, controlled, and blinded study. All 200 patients were monitored with cerebral oximetry, but 100 of them were blinded from the investigators, and the 100 that were not blinded followed a very tight intervention algorithm. What they found in this study was a lower combined morbidity and mortality endpoint than the control group, and also compared to the STS database of patients that were not monitored at all. An other interesting finding that they had in this study was that outliers in the ICU may reflect more than just cerebral ischemia. They may actually reflect end organ ischemia, that it's perhaps the device was able to detect overall oxygen desaturation in the body and not just the brain. So they concluded that regional saturation may be a useful measure of global perfusion adequacy, not just brain ischemia. Here's a comparison of the two groups. On the left is the control group. On the right is the study group that followed the intervention algorithm. As you would expect, because they were intervening before these patients had cerebral desaturation, they had none in the group that met their desaturation criteria, which was an area under the curve of change of more than of 30% change from baseline or less than 70% change from baseline. The area under the curve is not just the depth of desaturation, but the length of time that they spend desaturated as well. And that threshold that they set was not just um, a single change of more than 30% from the baseline, but also the percent in time. So it was also more than 150 minutes percent area under the curve. And like I said, in this group, there were no patients who met those criteria, but the control group had 6 patients that met the criteria, which was a significant difference. Here's the outcomes comparing those two groups. Again, orange is the intervention group. Blue is the control group. You can see that overall incidence of complications was less in the intervention group. And in all cases, the control group had higher incidence of these outcome variables, such as death, stroke, prolonged ventilation, reoperation, but no change in dialysis. The 11 patients in the control group, 11% of the patients was very similar overall to the STS database. Not only did they see less complications overall, but when they looked at the mean saturation during the procedure and compared that with length of stay in the hospital, they found almost a dose-dependent curve where the lower the mean saturation during the case, the longer the hospitalization or length of stay. Here's the interventions that were required in the intervention group to keep those patients out of the desaturation range. And you can see both the number of patients in the intervention group that required each of the interventions, as well as how efficacious each intervention was. Overall, the interventions were efficacious 80% of the time, but the majority of patients required at least more than 3 interventions, and that's not unusual in that it's not usually a single factor of why these patients desaturate during cardiac surgery, and so you have to really approach this to handle several different interventions in order to increase oxygenation to the brain. In this case, the most efficacious interventions were increasing pump flow while on bypass, increasing mean arterial blood pressure, or normalizing CO2. But you can see that the other interventions as well, deepening anesthesia to decrease oxygen demand or increasing FiO2, were also efficacious in this patient group. One interesting finding that was discovered was that in the control group, there was a wider standard deviation in the ICU length of stay. In a subgroup analysis, the investigators found that this standard deviation was caused by several outlier patients in the group, and it was felt by the authors that these outliers represented patients who had significant enough cerebral desaturation to result in organ dysfunction, and this was the source of the increased ICU length of stay in this group. Here's another study in cardiac surgical patients, this one more specifically in terms of high-risk cardiac surgical patients, where they also looked at interventions to reduce cerebral desaturation. This was also a multi-center randomized controlled blinded study with 200 patients. What they found was that desaturations of more than a 10% change from baseline were fairly common in 60 to 70% of patients. With the algorithm that they were testing in this study, they found that desaturations were reversible almost always in these patients. They concluded that desaturation was common and reversible. In this study, they were not able to detect a difference in major organ morbidity and mortality, but there was a trend toward better outcomes in the intervention group. Here's their intervention algorithm of how they proceeded. The interventions are similar, but what you'll see is these were done in a stepwise fashion. So here, if the patient desaturated, the first step was to check head position or cannula position, particularly if there was a unilateral reduction. This was important as the first step to detect the cause of desaturation. Second step is if there was hypotension to treat it. Third step is if the oxygenation, if there was hypoxemia, to treat it. Fourth step is if there was hyperventilation, to treat the PaCO2. Fifth, they increased hemoglobin if there was anemia. And sixth, they increased cardiac output either by increasing pump flow or improving cardiac function to improve SVO2 if the SVO2 was low. And lastly, they took steps aimed at reducing demand. So if needed, they instituted hypothermia or reduced intracranial hypertension if they thought that those were the source of cerebral desaturation. And in this, using this algorithm, the investigators were able to reduce desaturation almost universally. What about more subtle findings related to cerebral desaturation? Here, this study looked at the impact on neurocognitive function after CABG. In this study, they looked at patients with asymptomatic carotid disease, relatively small number of patients, but a prospective double-blind trial nonetheless. These patients were all undergoing CABG surgery. They did both pre and post Montreal cognitive assessment testing, which is a very sophisticated test to look at neurocognitive function. What they found was that patients in the control group had lower cognitive function scores postoperatively by up to 44% compared to 16% in the intervention arm. And they concluded that NIRS can have a reduction in cognitive decline in patients undergoing coronary artery bypass grafting with asymptomatic carotid disease. Here was their algorithm. It's a little bit easier to apply than the one we just looked at. However, the principles are really very much the same. If cerebral desaturation occurred, the first thing they did was check for head position and cannula position. If there was hypotension, raise the blood pressure. Hypoxemia, raise the FiO2. If there was hypercarbia, to raise the PaCO2. If there was anemia, to treat it, and if none of those interventions worked, they would reduce oxygen consumption by either deepening anesthesia or a reduction in temperature. So you can see the same principles here, but a very much simpler algorithm to apply. Here's the results from this study. You can see the two groups here, the NIRS group and here the control group. This is preoperatively. You can see these groups are very similar, but if you look here postoperatively, the control group had a higher percentage here, 44% incidence increase in mild cognitive impairment in their cerebral functioning, a small but not statistically significant increase in serious impairment after surgery, and lower scores on the testing indicating less severe neurocognitive dysfunction in this group. And if you look at this plot, which plots their scores, their MoCA scores, versus the number of patients in each group, you can see that the orange represents your cerebral oximetry group, where they had more patients with higher cognitive functioning scores compared to the control group, which had lower overall, higher number of patients with lower cognitive functioning scores. Another study looking at neurocognitive decline, this one doing both pre and post cognitive testing at 7 days. Another study with slightly larger number of patients, here 200 patients, again prospective randomized double-blind study of patients undergoing coronary artery bypass grafting. The incidence of cognitive decline was lower in the intervention group, almost half. And what the interesting finding from this study was that prolonged desaturation, so not just a brief desaturation, but if the desaturation was prolonged, this was highly associated with an increased risk of cognitive decline, and actually a 12-fold increased risk of cognitive decline in this group. Here, as you can see on the multivariate logistic regression, these are odds ratios with positive numbers being more associated with predictors. And you can see here prolonged regional oxygen desaturation was associated with a 12-fold increase in the multivariate logistic model. Finally, just so that you don't think that all problems with cerebral functioning is related to hypoxemia, this was a study specifically looking at postoperative delirium, a prospective study with 310 patients undergoing cardiac surgery, assessed with CAM ICU, which is a delirium measurement tool used postoperatively in the ICU. And what they found was that a 10% per hour association of intraoperative hyperoxia, so here patients with increased levels of oxygen, resulted in an increased odds of delirium. And hyperoxia pre-ischemia also was associated with delirium. So they concluded that interoperative hyperoxia is also associated with postoperative delirium. So you can't just provide increased levels of oxygen with the hopes of impacting the neurocognitive decline in these patients or the delirium in these patients. So to summarize some of the cardiac surgical studies, we know from the studies I just showed you that intraoperative cerebral desaturation is associated with worse clinical outcomes, worse cognitive function, and potentially an increased incidence of delirium, and increased evidence of not just cerebral, but also global organ hypoperfusion. A structured intervention algorithm, I showed you a couple examples of that, nearly always reverses desaturation in cardiac surgery, but we also know that cerebral hyperoxia and hyperoxic reperfusion injury may be associated with delirium as well. So moving on to the second group of clinical studies that we'll look at, this is related to carotid endarterectomy procedures. Monitoring in carotid endarterectomy is complicated, and there is no gold standard monitoring for carotid endarterectomy. There is no one perfect monitor. EEG is probably about the closest that we can come. However, you can see it's not very practical for most patients in the operating room. This is cumbersome and difficult to apply during carotid endarterectomy surgery. Transcranial Doppler is a possible technique as well, but very much heavily relies upon the operator to be able to use transcranial Doppler successfully. Keeping the patient awake and doing surgery under local anesthesia is also a good monitor for cerebral ischemia during carotid endarterectomy, but may not be practical and may not be something that is preferred by the patient or the surgeon, which leaves a cerebral oximetry as a very practical and useful monitor for cerebral ischemia during surgery, particularly in helping to determine whether a shunt can be needed or not. So this was a study in 94 consecutive patients where they were really looking to determine whether cerebral oximetry could tell whether a shunt was needed. They compared cerebral oximetry to and transcranial Doppler to EEG in these patients. And what they found was that they determined that a need for the shunt was needed when they detected a 20% decrease in regional saturation. And this was found in 8% of the patients. The rest of the patients did not require a shunt. This is important because we know that placement of a shunt is associated with complications and worse neurologic outcomes. So if we can avoid a shunt, that's better in carotid endarterectomy carotid endarterectomy surgery. None of the shunted patients developed neurologic sequelae in this study, but they determined that selective shunting can be safely used and guided by cerebral oximetry. Here's another study also looking at cerebral shunting in carotid endarterectomy. A little bit also a good sized study with 151 patients undergoing carotid. Again, comparing transcranial Doppler to EEG to determine both the positive predictive value and the negative predictive value of these monitoring techniques by comparing them to EEG. Based on EEG changes, 11% of patients required shunting, and both NIRS and transcranial Doppler performed moderately well as far as positive predictive value, but both had a very high negative predictive value for detecting cerebral ischemia. Negative predictive value means that if there is no desaturation, the chance of any adverse neurologic outcome is very low. Here for cerebral oximetry had about a 58% positive predictive value and a 99% negative predictive value for EEG detected cerebral ischemia. This is what the receiver operator curves look like for the devices here with cerebral oximetry in orange, and you can see the closer the curve is up to this point, the better the device at detecting the problem. And so both in orange is cerebral oximetry, and blue is transcranial Doppler, both very good with EEG detected cerebral ischemia. But certainly from a practical standpoint, it was easier to use the cerebral oximetry and more practical for these patients. And then finally, looking at a specific algorithm for selective shunting in carotid endarterectomy. This study was prospective randomized controlled trial of 253 patients undergoing a carotid. They compared NIRS with an algorithm, NIRS without an algorithm, or control group on shunt. And compared to the algorithm group, the NIRS with no algorithm group had 3.7 times, and the control group had 70 times more shunt use, with no difference in neurologic outcome in this patient group. So the use of a specific algorithm based on cerebral oxygenation can aid in the decision for shunt placement, again, shown in this study. And here's the interoperative algorithm that they used to determine at what point it would be required to place a shunt. So in summary, cerebral saturation can be a practical parameter in carotid endarterectomy surgery by identifying the early signs of cerebral ischemia and indicating the need for and proper placement of vascular shunts. If we can avoid them, and we can use an algorithm to guide selective shunting in carotid endarterectomy, we expect to see a benefit for neurologic outcome in these patients. Next, we'll take a look at studies related to beach chair surgery. The physiology of beach chair surgery is incredibly complicated, and there is some controversy regarding appropriate blood pressure management and how the physiology reacts when patients are placed into the beach chair position. Most believe that if you increase the head above the site of blood pressure monitoring, you have to apply a correction factor for the hydrostatic gradient that exists from the site of non-invasive blood pressure monitoring, here, for example, in the brachial artery here in the arm, and the height difference to the brain, which here can be reflected by the auditory canal or the top of the head. And if you use a correction factor, which you can see here on this slide, you can see that the difference in mean arterial pressure from the site of monitoring to the brain is quite significant. And if you monitor in other places, it's not uncommon to monitor the calf in many of these surgical procedures. You can see a very high gradient between the brain and the site of monitoring. Just by changing the angle, and here to this picture on the right, going to a 70-degree angle from a 45-degree angle, you can see the impact that it would have on the difference in mean arterial pressure at these various sites. And if you couple this with the need for blood pressure control to reduce bleeding in these surgical procedures, as well as kind of unknown variations in cerebral circulation in patients, you can see how mean arterial pressures at the brain could result in significant neurologic outcomes and problems in selective patients in this group. Here's just a simple case example of what happens to a patient who gets sat up into beach chair position. This is a 56-year-old having a rotator cuff repair. He's got hypertension and sleep apnea. Here's the baseline cerebral saturation of about 75, right in the normal range. We sit up, and this is what happens to his bilateral cerebral saturations. Despite what would be noted to be an adequate mean arterial pressure, adequate oxygen saturation, this patient had a significant cerebral desaturation. Despite an adequate blood pressure at the site of measurement, this patient was treated with some ephedrine. With increase in the blood pressure, this cerebral desaturation was reversed and maintained throughout the rest of the surgical procedure. Here's a study looking at shoulder surgery in the beach chair position. This was 218 patients undergoing shoulder surgery in the beach chair position. In this case, patients were randomized to be beach chair versus lateral decubitus position. They measured cerebral blood flow autoregulation using the cerebral oximeter to determine the lower limits of autoregulation. They looked at neurologic outcome and also serum markers of neurologic injury. What they found was that autoregulation was diminished in the beach chair position. Not surprisingly, the mean arterial pressure at the tragus was lower in patients in the beach chair position, as well as their cerebral saturation. There was not enough patients to detect any difference in cognitive outcome or neurologic injury in this patient group, but they determined that beach chair position had a major impact on autoregulation in this group of patients. Here's the data from this study. In this column, you can see the patients in the lateral decubitus position compared to patients here in the beach chair position. Despite having a higher blood pressure overall in this group, all of the 109 patients in this group, they had a lower estimated average mean at the tragus. You can see a significantly different lower mean pressure compared to the patients that were lateral. They had lower mean cerebral saturations compared to patients in lateral decubitus position, and they required a higher mean pressure to achieve the lower limit of cerebral autoregulation based upon measurements with cerebral oximeter compared to patients in the lateral decubitus position. Another study looking at beach chair position to see if desaturation events were more common. And here they had 63 patients in the lateral position, 61 patients in the beach chair position. They measured cerebral desaturation events as more than a 20% change or an absolute value change below 55 for greater than 15 seconds. And measured recovery. They found that the regional saturations were lower in the beach chair position. There were 80% incidence of desaturation events in the beach chair position compared to 0 in patients that were lateral. So significantly more desaturation events in this group. And they had a higher incidence of postoperative nausea and vomiting, which the authors of this study postulated could have been due to cerebral ischemia, which has an influence on postoperative nausea and vomiting. Here's what it looked like. The blue are the patients in the beach chair, and really throughout the surgical procedure, you can see that once the patient went into the beach chair position, the regional cerebral or the cerebral saturation here was lower compared to patients here overall in the lateral position. And finally, another final study looking at beach chair position. This was a prospective randomized trial with 56 patients. They were looking at the impact of the type of anesthetic agent, whether it was an inhaled anesthetic agent or an IV anesthesia agent, compared as well as the impact of changes in FiO2 and minute ventilation and the impact on cerebral saturation. What they found was that cerebral saturation did decline when patients were in the beach chair position. Both the intervention of increasing FiO2 up to 100% oxygen and permissive hypercapnia reversed cerebral desaturation. I'll show you what that looks like, but there was no effect on the type of anesthetic that they used. So they concluded that both moderate hypercarbia or permissive hypercarbia and normal baric hyperoxia attenuated desaturations. Here's the schematic of what they did in this study. Here's the patients at baseline with an end-tidal CO2 of 30 and an FiO2 of 30%. Then they moved up and put these patients using the same ventilation strategy. They put them in the beach chair position, and you can see these patients desaturated in both the blue and the orange, the propofol, which is the IV anesthetic group, and the orange, which is the inhaled anesthetic group, both decreased from baseline. Then they increased the FiO2 to 1%. This repaired the desaturation in both groups. Then they allowed permissive hypercapnia, so they decreased their ventilation, allowed end-tidal CO2 to rise, and the cerebral saturation went up actually above baseline. And then just to prove that that's what they were seeing, they went back to the original strategy, and the attenuation in cerebral saturation was reversed, and they went down again to just below baseline. So really showing very dramatically the impact of FiO2 and ventilation strategy on the incidence of cerebral desaturation in these patients. So just in summary, for beach chair studies, cerebral desaturations we know occur very frequently in the beach chair position, although it's very difficult to find neurologic consequences or worsening outcomes in the studies that we looked at. Beach chair position is associated with more cerebral desaturation, decreased autoregulation, and we know lower mean arterial pressures at the brain, which could be the consequence result in severe neurologic injury. And moderate hypercarbia as well as normal baric hyperoxia can attenuate desaturations that were associated with the beach chair position. Risk stratification, cerebral oximetry can be used to risk stratify patients. In this case, risk stratifying patients before cardiac surgical procedures. In this study from Germany, they looked at 1,000 consecutive cardiac surgical patients, and instead of looking very specifically at intraoperative cerebral desaturation data, they wanted to see what would happen if they looked at the baseline when they placed the cerebral oximetry pads on these patients before induction of anesthesia, before surgery. And what they found was that a low baseline was associated with increased morbidity and mortality. And it was even more compounded by patients who, when they went to pre-oxygenate these patients, did not respond to oxygen treatment. Those patients were a very specific group of oxygen non-responders who had significantly worse outcomes. And what they determined was that regional or cerebral saturation can be a very positive and very powerful screening tool to predict risk, to predict risk after cardiac surgical procedures, as well as an important intraoperative monitor for ischemia. If you remember earlier, I showed you a curve of what normal cerebral oxygen saturation looks like. Here's the 1,000 consecutive cardiac surgical patients. You can see that their mean is lower. The other patients were between 60 and 80. These patients are kind of between 50 and 80. And importantly, there's this tail out here to the side in cardiac surgical patients where we have patients with significantly low baseline cerebral oximetry values. When you look at these low baselines and plot them as hazard curves for survival, what you see here is in blue. These are patients who responded to oxygen compared to patients who, when given an oxygen challenge, did not respond. Here's their reduced survival probability out to 360 days. So this is 1 year after surgery. Patients who were oxygen non-responders did very poorly. And here, when you look at a very specific cohort of very high-risk patients, these are patients with a Euro score greater than 10. You can see that the difference between the oxygen responders and the oxygen non-responders is even more pronounced, where the survival curves for these patients below 50% at 1 year for survival. And these risk scores were even more powerful and predictive than both STS score and Euro score for predicting adverse outcomes after surgery. Can the preoperative cerebral saturation also predict delirium? This study looked at 231 patients undergoing cardiac surgery, both pre-intraoperative and also looking at, again, the CAM ICU delirium scale. And what they found was that the independent predictors for delirium, all the things that we kind of associate with delirium after cardiac surgery, such as old age, lower preoperative neurocognitive scoring, pre-existing neurologic disease, but also low preoperative baseline below 60%, were also predictors of delirium in these patients. And here's the odds ratios. You can see here's age. So this is older patients. If you were more than 70, you had a four-fold increase risk of delirium in undergoing cardiac surgery. And by comparison, here's your baseline cerebral saturation. After pre-oxygenation, if it was less than 60%, you can see you had a 3.5-fold increased risk of delirium in this patient group. And here is delirium classified by normal or low cerebral saturation. Here's the patients with a baseline less than 60 compared to a baseline here greater than 60. And you can see the differences in delirium in these patient groups. And one final study, this is 2,000 consecutive patients with looking at their baseline values. It did a retrospective review of the STS database, and if the patients had a baseline value less than 60, they had higher STS mortality scores. This was after adjustment, so our cerebral saturation, although slightly less accurate, it was found to be easier to use than the STS score, but pretty comparable for predicting mortality after cardiac surgery. And here's the postoperative outcomes in these patients. Here's the cerebral saturation greater than 60 compared to less than 60. And you can see the differences between these patients with a longer hospital stay, a longer ICU stay, and a significantly different increased risk of mortality in this patient group. Here's another study looking at baseline cerebral saturation and delirium, prospective randomized double-blinded trial with 250 subjects over the age of 60. There was no difference in delirium between the control and the intervention group. They did find a 25% incidence of delirium in the overall patient group, but not only were small BMI a predictor of delirium, but again, a baseline saturation less than 50 had a more than threefold increased incidence of delirium in these patients. And we'll move on to the summary slide, and then move to the last topic. Here, baseline saturation predicts mortality and morbidity in cardiac surgical patients. I've shown you several studies that showed that. Baseline cerebral saturation compares favorably to other models, and it's easier to use for risk prediction. And it predicts the incidence of delirium in cardiac surgical patients as well. And finally, the last topic that we'll talk about here is blood management and transfusion management. Cerebral oximetry can be a useful tool to guide transfusion. In this study, it was a prospective randomized trial with 150 patients that followed a protocol for using cerebral oximetry to guide transfusion decisions compared to the control group. The protocol group did show less transfusions and less overall volume of red blood cells transfused. They concluded that the monitoring system was a useful guide to help with objective data to manage transfusion decisions, resulting in less overall transfusions for these patients. And then what about in pediatric cardiac surgery, where transfusions are more common? This was a retrospective study looking at pediatric cardiac surgical patients, 91 patients under the age of 2. What they found is the usual factors such as low weight was independently associated with transfusion, or in this case, high weight was associated with lower transfusion, but also cerebral oximetry was associated with a lower transfusion threshold. By monitoring these patients and determining the oxygen cerebral ischemia threshold, they could withhold transfusion with less volume, and they also found a shorter length of stay in this patient population. Here's the data from the study. Here you can see the no cerebral oximetry group versus the cerebral oximetry group. with lower volume of transfusions in weight per kilo. Here's the total volume, lower here, and a shorter ICU length of stay overall. We'll go to the summary. Here, cerebral saturation monitoring can be useful as a measure of global perfusion, and cerebral oximetry monitoring as part of a blood management strategy can reduce the incidence and volume of transfusions in both adult and pediatric cardiac surgery. So in conclusion, what we've talked about today is that aging, increased comorbid conditions, as well as complications are difficult. They're common. They're very difficult for us to treat. They present a threat to high quality outcomes in surgical care with a increasingly older and increasingly sicker patient population. Regional cerebral oximetry can provide both therapeutic guidance as well as hemodynamic for hemodynamic monitoring, as well as detection of hidden threats that can impact cerebral perfusion. In each of the cases, specific cases today, we talked about how the device can be a value-added benefit to help the anesthesiologist ensure outcomes expected in today's healthcare environment. And this is a technology that can hopefully improve outcomes in these groups and reduce the costs associated with complications and longer lengths of stay. Thank you very much, and I appreciate any questions.
Thank you very much, Dr. Green. These are the references for your presentation. Can you go to the next slide, please? So for those of you who want to receive a CME or CE accreditation for this event, please go to successtesting.com/INIT in it, and there you will be able to complete the test and the evaluation and receive your certificate. Next slide, please. Now, to be respectful with the time of everybody, today we are not going to have questions because we have run over the hour that we had allocated to this event. If you have any questions, yes, send them to us and we will make sure that Dr. Green receives them and sends you an answer to your email. With this, thank you very much and have a great rest of your day.